academic center, but also in a lot of community centers. So we thought it would be important just to give you some kind of key principles plus practical tricks based on the medical education literature that exists, and it's quite abundant actually. So sometimes I think people feel that if you're an expert, you're automatically a teacher. Well, there's kind of a bit of a different skill sets, and it certainly helped to be knowledgeable in a domain and competent to be able to teach, but that's certainly not enough. And those are the things that we're going to discuss a little bit more. Alyssa was kind enough to agree to present today, and that's certainly within her realm of interest and expertise. So we're quite lucky to have her. The first part will be a little bit more kind of theoretical and discussion, and then there's a couple of cases that we'll go through in small groups for the second part of the session, where you'll be confronted to common, let's call them educational challenges, and just discuss with your peers what you would do in those situations, because they will certainly occur if they haven't already. So Alyssa, I think I will let you take the lead and be in the background, and hopefully not interrupt you too many times, but I also will keep an eye on the chat box.
Thanks so much, Dominique. Thanks for that very kind introduction as well. So a lot of people here are super familiar, but for those that I haven't had the opportunity to work with yet, my name's Alyssa, and I'm one of the recently graduated, as of I think like officially two and a half weeks ago, fellows out of the critical care program here in Toronto, now kind of doing some community ICU work out at Lakeridge that Varuna and Nassim also come out to, and then also doing internal medicine work at Mount Sinai Hospital. So hopefully we get to meet in person at some point. I've got some objectives for today, and I recognize that much like this pizza with little pizzas on top, this is teaching about teaching, but I'll try to make it practical and relevant. So here are the objectives. So we're going to review the importance of fellows as teachers. We're going to talk about evaluations and provision of feedback, some tips for teaching on rounds, some tips for procedural skills teaching, how to prepare for and deliver didactic teaching sessions. And then, as Dominique mentioned, we've got some small group cases about actually kind of semi-modified, but truly and honestly based on real life scenarios that I've encountered in my role as a clinical teacher working with residents. That should be a good discussion point for, how to approach kind of tricky situations and provide, appropriate feedback.
And just, sorry, Alyssa, reassure me, you haven't tasted this thing, right? You took that on the internet.
Yeah, no, it's called the Meta Pizza. It came up on Reddit like many years ago, and I really like the image, especially for sessions like this, teaching about teaching. But no, I haven't eaten it. It does look delicious though.
Varuna, I don't agree with that. I'm sorry, we'll have to disagree on eating that thing.
So before we kind of dive in, I just want you guys, everyone, just take a second and think back to your first time entering the ICU as a learner. How did you feel? What did you learn? Who taught it to you? And who were the key people involved? And when I reflect back onto my own experience, I really did feel like a bit of an imposter, like I was kind of playing dress up as a doctor almost. Everything was super unfamiliar. And a lot of my early memories are tied in heavily with, the other residents, fellows, and staff that I was working with.
Is anybody would like to share if you put yourself back, because I think it's kind of a good exercise to go back and think about what you wear and reflect a little bit, because often these are, this is the kind of reaction that people will have when they start in the ICU, and sometimes we'll forget how this can be a bit overwhelming for the learner. I personally was sent to CT as soon as I put my feet in my first IC rotation. I was a PTY1 because as where I train in Montreal, and some of you might be well aware of that. But when you're a GIM resident, you do all your call in the ICU at night, starting PGY2, regardless of where you're doing your rotation. So therefore, as PGY1, you want a bit of experience because you're going to be first call in the ICU in July. So the first rotation as a PGY1 was sent to a CT with a patient who had the deterioration of this level of consciousness. As I was, as a dedicated Bailey physician, re-examining the patient before he would just go through the machine, one of the pupil was dilated. And I therefore did nothing and just called the team who just arrived in catastrophe and kind of took over, but I rolled the patient back in the ICU. And later on that day, so the first central line that I put was actually a retro jugular line for continuous monitoring of the venous side, cerebral venous side, which with reflection, I'm quite admirative of my senior resident PGY3 who had never done that. I mean, he had done plenty of lines, but not that specific lines. And instead of just taking it away from me, he said, no, we're going to do this together. And so that's the first line I put. But reflecting on that, other than being kind of terrorized, I'm quite admirative now that senior resident just let me do it, even if that would have been probably a pretty good learning experience for him. Anybody else had a remarkable start in the ICU or memorable teaching moment or learning moment in the ICU?
Yeah, I can share if you want. I did a rotation in the ICU when I was a medical student, like an elective rotation, and it was in a center where we didn't have ECMO, and a patient who was post-operative, I think day 2 or 3 from a prostatectomy, coded on a massive pulmonary embolism, and the interventional radiology team was not available. They were stuck in another hospital. So the ICU attending, he decided that we were going to thrombolize him, and we did. And the patient afterwards had a massive transfusion. I think he had 35 or 40 units of blood, went back to the OR, but just like everything was oozing. The patient ended up like doing quite fine in the end, but I was totally traumatized by the experience. I was like, this place is absolute madness. I'll never do critical care. Like, what's the point of all this? And here I am. So yeah, I got used to it, and I learned to see what drives an intensivist and what makes this job so interesting. But my first days as a medical student we weren't off to a good start. But yeah, it was. I was so impressed by the calm and how the intensivists manage. I was like, this is the kind of doctor I would like to be. So probably influenced me in some way too.
And I like Veruna's comment about not knowing anything about ECMO, but also very little about ABG.
Exactly, about nothing.
Maybe the order here should have been inverted. But I think you touch upon a super important point about patience, and I think we'll come back to that. But something that you might want to give back to your resident. Okay, that's great. Thank you guys for sharing a few stories that put us back in a few years back.
So, as a fellow, you're actually more important than you might realize. So you're going to be the most important teacher that the residents have during their rotation, to be perfectly honest. You're going to be providing them with the majority of feedback and evaluations, and you're going to be the ones that they look to for role modeling. So really important when you're, talking to them about patients and interacting with the interprofessional team. Just keep that in mind. And you're also going to be the ones that are setting the tone of the rotation for them. So, coming in with a positive attitude, an engaging attitude and willingness to teach is really important. And when we think about clinical teaching, there's this tendency to think that we're doing it kind of for other people. But really, like this quote, I know it's super corny, but some of the patient scenarios or some of the presentations that I'm the most comfortable managing clinically are actually ones that I've done extensive teaching sessions on. So it's actually a really good opportunity to consolidate your own knowledge, to read a little bit deeper, and to update yourself. Like before, running a sim or doing any teaching session, I look stuff up again and make sure that nothing's changed. And it is a really good opportunity to consolidate information for yourself too. So I promised myself that I wasn't going to dive too deep into the weeds here with med-ed theory, because I know that not everybody here is as big of a nerd as I am, but really social learning theory is at the heart of our day-to-day teaching and learning within the clinical learning environment. The residents learn through collaborating with us in the ICU, just like we learn through collaborating with our staff. Like lectures are cool and all, but it's really through doing things with other people that we grow and learn. There's also this idea of scaffolding, which means that through sharing or distributing the cognitive load, the individual performance becomes scaffolded by the people that they're working with. So when we're thinking about the trajectory of a learner who's coming through the ICU, there are certain things that they can do from the get-go, no problem. And there are also things that they won't be able to do, regardless of how awesome of a resident they are. But we're here to help them achieve new skills that they can develop with support and guidance. And fellows are key for helping learners achieve these new skills in what we call their zone of proximal development. These are skills and tasks that are too difficult for them to do independently, but they can do with some help. And you as the fellow, you're the knowledgeable person in this scenario that's kind of helping them through this. So when I think back through training, actually, some of the best teachers I had were just a year or two ahead of me in that kind of like near peer teaching zone, because they kind of know what you know and they know what you don't know, and they're there to help you get functional, really. So thinking back, it's like the PGY2 who helped me manage my first case of uncontrolled AFib, or the resident who walked me through my first patient who had critical hyponatremia. And obviously, these PGY2 residents, they weren't like world experts in their field, but they knew just a little bit more than I did. And they helped me get some of those like functional skills down pat. So it's important to realize that as a fellow, you're probably not the world expert in ECMO, like that's Eddie Fan's job to be the world expert in that domain. And that's just okay, because you probably know just a little bit more than the residents know. So it's really important to kind of acknowledge and try to get rid of that imposter syndrome that we all have, and just teach them the parts that you do know. So there's this kind of concept as well of legitimate peripheral participation. So the goal here is to take the learner from being an outsider in an unfamiliar clinical environment, and to help them, get them to the point where they can speak the lingo of the ICU and get them functional within the ICU setting. And a key part of helping them transition from an outsider to someone who's, comfortable in the ICU setting is through giving them opportunities for authentic contributions within the ICU. So I'd, encourage everybody, bring your resident with you when you go talk to the surgeon, and get them to lead the goals of care discussion with some, support and coaching before you throw them into a deep end environment. Explain what you're talking about when you're having some of those higher level conversations with the RTs about, your difficult to ventilate patient. It's really helpful to bring them from kind of outsiders, residents who really don't know where they are or what they're doing, to being really key and integral members of the team.
Can I just
Yeah,
add
for
to
sure.
that? So of course, those are theoretical concepts, but I think you can easily relate to what happens in the reality, right? So in the middle of a resuscitation, sometimes it's, it's going to be overwhelming for your junior residents, but it's extremely easy to delegate a very practical and important task to them that they are totally fine to do, right? And that can be check the vitals, that can be like keep an eye on the vital signs, or keep an eye on the blood pressure, or push the medication for anesthesia, for induction if you're going to intubate, even if you determine what is the dose. And that sounds all very trivial, but it's not. The more you make people feel like they're engaged and participating into real kind of clinical and important activities, even if their specific task is not vital, the more that they're going to give you back. It's a bit of an exchange, right? So if you push them away, people disengage, and then they don't feel great about the rotation, and we feel that they're useless. And it's a bit of a vicious circle, right? So even in any kind of, even if it's just in a family meeting, if they just sit there and hold a box of Kleenex, that's still an active role in a room, and that is important for all of us. And that's true for staff doing the same with the fellows, but it really has valuable impact on how residents see their importance, and then engage in the future in all the activity, and take responsibility for some of the tasks.
Thanks, Dominique. So there are some traits of excellent clinical teachers. If you're truly going to be excellent, you should have some engagement and passion for teaching. Other good traits to have are being accessible, approachable by your learners, and supportive. You've got to have some degree of clinical competence in order to teach effectively. Excellent clinical teachers will have a broad repertoire of teaching methods and scripts, and I'll touch on this again a little bit later. And then please try to target your teaching to the learner's level of knowledge. And that's actually one of the reasons why I think fellows are such great teachers, is because we remember what it's like to be a PGY2 internal medicine resident, where it's I don't really know very much about pressors or whatever the situation is. So, try to take things and teach things that are relevant to the learners in front of you. You can find stuff even for the PGY, one ortho resident who's doing this mandatory rotation. There's stuff that you can teach them that is actually relevant for them. They're going to be called in the middle of the night with ward emergencies, and giving them their, first 5 minutes of management for certain things is actually extremely helpful, and they're very appreciative.
Can I ask the group, what are the kind of strategy that they've used to do that? Because I know a lot of you have been teaching for years, so you're not necessarily obviously novice in that task, but what are the tricks that people have developed to do that? How do you figure out what the learner know, right? We have a new group of residents every month, every 2 months. You don't know them. You often don't work with them for very long. Sometimes you work on them just for a call. So how do you figure out what they know and how you can, okay, perfect. So asking question, what they want to achieve from a rotation, that's helpful. Certainly we should do that as rotation supervisor. And that's often something that can be done at the beginning of rounds, at the beginning of a call. If you're going to work all night with a resident, what do you want to get away from this call? There's specific things. People are not always able to articulate clearly, at least in my experience, what are their learning needs, because especially if you start in the ICU, you know nothing, or you never know nothing, but little about critical care ICU, and you're not sure what you're going to encounter overnight. Obviously, it's a bit difficult to do around ahead of time. Questions are really important. They're a bit of a double-edged sword, and I think Alyssa, you're going to talk a bit about that. But this is not an inquest, right? So if your poor resident feels they're under the spotlight and they're being questioned and roasted, in order to show what their areas of ignorance are, that's not going to go well. And we'll talk about it later, why this is not a good idea. But absolutely, that's the only way to know what they don't know. So always ask them, even if they say the weirdest thing, or ask a bizarre question, have the curiosity to say, why are you asking that? Or just tell me what you're thinking, because probably often the gap is not where you think it is. And you kind of need to make a bit of a diagnosis on the weaknesses of the trainees. So so ask questions and have the and then adjust what you're going to say based on what they reply. So asking question is a good idea, but don't do that in a threatening way. And then it's not, the Socratic method is should be in the past, according to me. Just pimping people all the time is not necessarily very productive. And yeah, talk to them, get a sense of who they are, ask them at the beginning of a call or a rotation, like which level they are, and what subspecialty they are, and what they're interested in getting from the rotation. Absolutely. Yeah, you can absolutely start very, very basic, and then you escalate based on what people know, and never assume that people know. Everybody has heterogeneous experience. Often if I teach fellow, I often assume that they know a lot, but it very varies. I mean, you all know a lot, but it really depends on what kind of clinical experience you have. If you haven't worked with a specific population, then, you might not know yet. So ask. And yeah, lecture, we'll talk about that. So sometimes there's a role for that, but usually not necessarily in the middle of some clinical activities. Okay, great. So I just wanted to keep things very concrete. I know, Alyssa, you'll talk about the script a bit later, but so I think targeting the teaching to the residents. I mean, some residents, you can teach them anything. They're going to be engaged and they look interested, even if it's not going to be helpful for them, but others need a little bit of teasing and making sure that you target a bit more the teaching to their needs.
Yeah, absolutely. Part of being a good teacher too, though, is establishing rapport with the trainees and being able to respectfully provide them with feedback. And this is truly a very, very important skill. And that's kind of like the focus of the second half and the cases that we're going to be talking about. But feedback, it's got to be specific. And it has to be about performance that you personally observed. It can't be like secondhand. That's why it's so difficult, these like end of rotation evaluations and stuff, that, residents are getting feedback from maybe the education site director, not necessarily always from a staff that they've worked with. And it might kind of, refer to a situation that really the person who's providing the feedback doesn't have all of the details about. So it really just becomes somewhat ineffective, which is why it's really important that you, as the fellows who are working with these residents day in and day out, or have worked with them for an 8-hour call shift, are the ones that are actually providing them with their coaching and their feedback. So it's got to be about stuff that you saw and observed. And the intent of the feedback is to help them. That's what it comes down to. And giving feedback, especially if it's corrective feedback, can be really difficult, especially for people that, you're maybe a year above them, maybe they're your near peers, maybe you've worked with them before, maybe you know them socially, maybe they're friends of yours. But it is very, very important to still do it, and to do it in a respectful way. And not all feedback is negative feedback. Residents who come through, they need positive feedback as well, because it can be extremely damaging for them to, come through a difficult clinical situation where maybe they did an outstanding job, but the patient deteriorated anyways. And they might go home that night and think that they killed the patient, or that some of their performance was inadequate and the patient died, or, even just regular stuff like rounding in the ICU. If you don't tell them that they're doing a good job, they're going to go home at the end of the day and think that they're doing a terrible job. Like, it's intrinsic in our nature as, type A personality physicians, that we all probably think that we're doing a terrible job all the time. So please do provide them with good feedback as well. Say, that was a great presentation that you did during rounds, or, you did a very good job managing that sick patient. Thank you for calling for help when you did, et cetera, et cetera. Dominique has her hand up.
Feel free to just ignore my hands, okay? What do people find is the most difficult? Constructive feedback or positive feedback? What do people find is the most challenging to deliver? Constructive? Yeah, yes, constructive means it's a Canadian way to say negative in the sense that there's some areas of improvement that needs to be targeted. So that's interesting. And I would tend to agree for many reasons that providing constructive feedback is very challenging, but I think we're doing a pretty bad job at providing also positive feedback. I think it has its own challenge, because telling someone that they're doing well, they're fine, everything is okay, they're on track, whatever other non-specific feedback that I'm sure you got over the years
At appropriate level, training at appropriate level.
Meet expectation, whatever, we're moving away a bit from those terms, but it's not specific and it's useless. So if you're going to tell a resident, I really like your presentation because you organized that, it was clear, it was organized, you put the priorities in the right order, and you actually took into consideration in your plan with the other healthcare professionals, say, well, that's a bit more informative already. So not that just the balance is positive or negative, but also what they did right is as important as trying to explain someone what they did not do properly. And I found it very difficult sometimes to provide informative or useful feedback to people who are doing extremely well, because they're doing extremely well, and sometimes it's not clear why they're doing so well. So put that in words explicitly sometimes is a bit challenging, but that's the only way it's kind of useful, because if you just said you're doing fine, that doesn't really help. That doesn't reinforce specific aspect of performance that should be, continue to be used in the future. We'll come back, as Alyssa said, a lot of the little exercise later are related to providing more constructive feedback. So we're gonna move along for now.
So one of the things that's kind of important to recognize is we, as the teachers in this scenario, we think that we're giving feedback all the time. But what actually comes into the trainee's mind as the one who's on the receiving end of that feedback or engaging in that feedback is that there's actually less than we think getting across. So I think it's important also to label what you're doing as coaching and feedback before you give them, that coaching or that advice or that feedback, label it as such. And I often find it very helpful to say, why don't we talk about this? Let's do some coaching here. That's what I usually frame it as. Let's do some coaching, let's do some feedback, and then take them through it. So there are some different frameworks for effective feedback provision, and this is just one of them. Observing the learner, asking them for self-assessment, and then comparing their self-assessment to your own assessment of them in terms of whatever standard of performance you have in your mind, and then trying to understand the gap between their own self-assessment and your assessment of them is really important too. And sometimes it's an expectations thing. And, that's part of our role as a clinical teacher as well, is to set very clear expectations about what you want the residents to be doing, because they don't know what they don't know they're doing wrong or right. But making expectations clear from the get-go when you're working with residents is a really good way to avoid some of the performance issues that you will for sure and inevitably deal with later down the road.
And can people think of why we're asking people to, I'm sure you've heard that phrase before, like, how do you think you did? How did that go? Which are the usual kind of little sentences. Yeah, okay. So, and to see if there's any insight into the performance and how is that useful? Okay, David, can you Can you expand a little bit on that?
It basically is just whether you are sort of conscious of your own competence or incompetence or not. So, you know, there's that Dunning-Kruger effect that I think people are aware of these days more with social media, and people don't know what they don't know, so they kind of will believe anything. But in sort of a medical sense, there's sort of those 4 blocks where you are consciously incompetent, unconsciously incompetent, consciously incompetent, and then you achieve excellence when you are sort of consciously competent or unconsciously competent. Sorry. So those are like the 4, and you sort of work your way through it. But the idea basically being that if you don't know what you don't know, then you probably overestimate your skills, and you sort of progress through those 4 stages to like excellence, I guess.
Yeah. And Alison, I think Alyssa, sorry, I don't know why I call you Alison. I think you have a slide about that later,
Yeah.
right? So I'll leave that to you. But I think, so a couple of things, well, 2 things, very short. So the first is just to say, so we're asking people to self-assess, not because they're very good at it. So we know from the literature in medicine and elsewhere that as human beings, we're not good at self-assessment. And you are right, David, that often people are, you know, could do better, tend to overestimate, and people who perform highly tend to underestimate themselves, although there's a fair bit of a range. And there's nothing wrong. It's not because people are doing this intentionally. It's probably a pretty effective self-protective mechanisms against depression for people, at least for people who may be underperforming. So we're not asking them to get, you know, a fair, you know, another point of information about their performance. We're asking them mostly because depending on how much insight, it's going to certainly frame your conversation with that person, but never forget that feedback is really an interaction. Yes, you're part of it, and you're, you know, providing the feedback. But if there's no acceptance of what you're being said, and if the person doesn't integrate what you're telling them into their own personal belief about how they're doing or how they did, you're not going to achieve anything. So sometimes it just allowed you, as others put it in the chat box, to see how much gap is there between what I'm about to say and what I thought, or how I judge this performance, and what the person think. And often actually it also refocused things completely, because people perceive something they did that was not a big deal as the main issue. And it just allowed to get that out of the way and say quickly, like, you know, that's not really the problem. Like, that was not really a problem. I'm not concerned about that because of that. However, like, this aspect, I think we should discuss more. So it served a very specific purpose. It's not just to say, okay, well, you go first and then I go, and let's make this. You actually have to pay attention to what people are saying and let it affect how you're going to present the information you want to give. Yeah, to harden themselves, absolutely. And confidence is important. And we'll come back to that a bit later. Go ahead, Alyssa.
So, you know, as the ICU fellow, I like to think of myself as the coach, you know, like when your team is shining, you are shining too. And, you know, like it's not a performative thing. It's for the purpose of patient care, right? So giving them that sometimes difficult or corrective feedback, it's really for the benefit. Everything that we're doing is so that we can provide better patient care. That's the crux of it. So putting yourself into that sometimes uncomfortable situation of providing that, you know, corrective feedback is really, really important. And framing it as coaching is also, I think, very helpful for learners to kind of integrate it and to make it, rather than this big kind of like daunting thing of like, oh, we need to sit down for some feedback. It becomes like, you know, let's talk about this. Here's the different strategies that we can use next time, you know, we're faced with a similar encounter. And maintaining team morale is also really important. So that's like another big aspect of the coach, and being the ICU fellows, we deal with some like really difficult situations in the ICU with patients, with families, with angry families, with, sometimes with attendings even that are a little bit difficult, to engage with and work with. And you're really kind of the leader of your resident team, and making sure that everybody's like happy and functioning and, getting what they need out of the rotation is also a very important and very gratifying job. Before we move on to evaluations, was there anything else that anybody wanted to add? I see some activity in the chat there.
Well, I think Marina was just looking maybe for some discussion about how to reassure a learner about their abilities that are often extremely high, and also about just now the timing of feedback. And she pointed out that some feedback needs to be given called for better processing. So any thoughts about that, Alyssa?
Well, to the first point about like teaching learners that are sometimes like stronger than you, everybody brings different clinical skills into the situation. And like, I think even like a couple of months ago, we were doing some case scenarios. I think David was in the small group, and we had one of the fellows who's like a neurosurge resident, and we were talking through that challenging case of the lady who had the subarachnoid hemorrhage and then the rebleed. Obviously, I do not know as much as the neurosurgeon about managing this. So harness your learners' skills and aptitudes. Like if someone knows more about a topic than you do, ask them to teach you a little bit more, or give a little bit more information to the other learners. Like we're all there in some capacity to learn, even as the staff. There's other specialists that for sure know more stuff. So just being open and authentic about it, and asking people to contribute what knowledge they have is better for everybody.
I really
Dominique.
I was about to say, I really like what Julien, sorry, I should pronounce this properly, I've learned other old names, put in the chat box. I think that's the key. I think the best way to make trainees, if not more confident, self-confident, at least less self-aware, is really to show your own gaps and weaknesses. I think if you function in an environment where your staff and then your fellows never say, you know what, I don't know, you know what, I'm not sure what to do here. There's no clear path here. We're going to have to wait and see how things pan out. I don't know about this. Let's kind of look it up and read. Or I don't remember that study. We'll have to look at it again. And the more you hear that around you, the more you feel comfortable yourself just saying, I'm not sure, I don't know. Why don't we talk about this? And showing your own ignorance. So not only, and that's true for the staff, that's certainly true for the fellows, but if your senior or, your supervisor is able to be very honest about their limitation, what they don't know, and the fact that a lot of this, even if you knew something 2 years ago, trust me, you will forget about it. And then it's okay to just say, I don't know, or I knew this, I forgot. And it makes a huge difference in terms of the climate that you create. And then having people who are willing to ask questions, and not feeling threatened by showing that they don't know something or that they did something maybe not optimally. So I very much agree with your comment, Julien. Yes, PTY fibrobatologists are certainly very impressive. Yeah, so I think being humble as physician and just very I think humility is important. I think if you don't stay humble in that job, trust me, you have every week a reason to be humble because one of your predictions didn't turn true, or you got something wrong, or you thought something and something else happened. So I think not only being humble, but also expressing that explicitly in front of the trainees. I think that's the part that matters a lot from a learning perspective. So yeah, we tell ourselves all the time, oh shoot, maybe I should have done that, or maybe that was not optimal. But the difference for in terms of learning environment is to actually express that verbally. So I think that's important in terms of the timing and feedback. So there's no right or wrong answer. I think for me, the big dilemma is if something was suboptimal overnight, do I discuss this with the fellow or the resident post-call, or I sit on it and possibly lose the opportunity to do so because, you know, who knows where I'm going to be and where that person is going to be the following day or when they're back, right? So what do people think about that?
Come on, guys, we've all been there. It's like your post call at 7 a.m. and you feel like you're getting attacked by the staff. Like this is like a universal thing that we've all been on the recipient end and also potentially on the giving end.
Yep.
Yeah.
I think it's tough. Yeah, I think people feel that too. And I found myself certainly making comments on rounds, nothing major, like some minor stuff, like saying things sometimes, oh, I'm not sure I would have given that or whatever, just as like for stuff that is not super important, but, and sometimes regretting those words because you can see the trainee's face falling apart and you're like, oh, that was not really important. It was just, you know, a minor point of management. And you know, God knows what I would have done at 4 o'clock in the morning anyway. So I think it's the problem is just practically in our learning environment, how to make sure that conversation happen a bit later, you know, because that could benefit the trainees. It's really, I found the challenge. So when we say timely feedback, it doesn't have to be immediate. And it has to be, you have to make sure that the trainees is somehow receptive. So if they ask you post-call about some specific feedback, well, I'm going to assume that they're ready to hear something. But then if I see that the reaction is maybe a little bit negative, or it seems to affect their well-being, then maybe I'll just readdress that in a day or two if I have a chance, just to make sure that that hasn't, you know, been reprocessed 3 times in the last 24 hours. So
there's so many good you know, comments in the chat here about really what it comes down to is feeling the situation out. You know, like one of the strategies that I've done before is, you know, I've said, you know, why don't you like message me later when you've rested, and I'll give you an update about the patient, and we can talk about any questions you had during their management overnight. And then it becomes more of a dialogue when they're feeling well rested. You know, I've gotten 3 p.m. text messages saying like, how's Mr. So-and-so doing? You know, we were managing that bleed all night or whatever. And then just opening it up for questions as a starting point. You know, we really struggled with the decision to do X, Y, and Z, and then framing it. I'm not sure, it might have been Varuna, but it might have been someone else I was talking to recently about teaching and feedback. But someone very smart said, you know, when you're framing things, you are one opinion and you are one staff person. And it's important to kind of acknowledge that with the trainees as well, saying, or sorry, you are one fellow that they are working with, saying something along the lines of, you know, from my perspective, when I manage this situation, I do X, Y, and Z. Other people might do something a bit different than that. You know, you might have been taught things before by other people. Like I was supervising a line the other day, and she, you know, the individual was like ramming it in at a 90-degree angle. And I was like, trying to like understand what was going on. And it's because they had been taught that from someone else. And so just kind of acknowledging that you are kind of one of many opinions. When you do it that way, you might do it a different way. And just being very open about it and making sure that they're ready to hear it. Because honestly, like we've all been on the receiving end of post-call feedback about something where it's like, that is such a nitpicky thing to say, and I'm so emotionally fragile right now. I cannot believe they're focusing on the fact that I used ringers instead of saline, or whatever the case may be, or saline instead of ringers, or whatever, which, like, yeah, okay, sure, for a TBI patient, yeah, sure, maybe we shouldn't be using a lot of ringers, we should be using saline instead. But like, it's like, you know, I've been awake for 24 hours. This is not the right time to have this conversation. Go ahead.
No, I was just about to say, on the other end, do not hesitate to give positive feedback post-call. That might give a boost to the resident you work with. So sometimes we're also tired, and we just, and you know, we might very much things like, wow, that was, you know, a nice person to work with, and they were so efficient and all that. Just, if you get a chance, just say that, and see what you liked about how they did and how they worked. Because that will always be well received regardless of the time of the day. And that makes you, maybe sometimes you feel crappy post-call, right? You feel everything was kind of a bit suboptimal because of the circumstances, and yet you've done a lot of good things. So so don't hesitate to say positive things. I think that's always helpful.
Yeah. So just to kind of blast through some of this additional material, you're going to be at the end of every block, or midway through the block, you're going to have the opportunity to provide narrative comments to the education site leads about, you know, performance with residents that you've worked with. So that's one of the methods of evaluation you're going to be involved with. And then you're also going to be expected to complete EPA, or entrustment of professional activity assessments, for trainees, much in the way that many of us require these about our own performance for our competency by design frameworks. And please try not to view it as like a tick box activity. I know ultimately it is literally boxes that you are ticking off, but it's an opportunity to provide them with some feedback about performance, and they do need these evaluations to move on. And try not to be tempted to make people competent, or, you know, excellent, or whatever, if they are truly not. You can be honest with these things and provide them with additional opportunities for skills to demonstrate integrated feedback. So what will happen is they'll pick you out of a drop-down list. You'll get an email in your inbox. You click the link, it takes you here. This is what it looks like. They'll give you a little prompt about what, you know, what activity it was that they want the feedback or evaluation for. And then you go through and you can tick the boxes of each of the different domains depending on what their level was during the activity. And please do try to fill out then strength comments about things that they did well, as well as some of the tips that you have for future. So this one was, you know, I supervised an art line. You know, the probe was flipped backwards initially. She had a bit of a difficult time cannulating the vessel because she was a bit off center. So I was just very specific about that in the feedback that I did, both in the moment as well as while I was completing the EPA.
Can I just say, sorry.
Yeah, go ahead.
Two things. So those EPAs are not going away. Many of you have to get some EPAs completed. And you will realize, I hope, as a supervisor, and hopefully that might influence your behaviors as a learner, that it's much, 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 much easier to provide feedback to someone when you know you're going to be asked to provide feedback. So if I'm in the middle of resuscitation, and sometimes even, you know, a challenging procedure, whatever, I focus on patient care. I don't necessarily have 100% of my attention on what the trainees is doing. So to be asked retrospectively to provide feedback to someone is a bit tricky. If someone asks me, we're going to intubate this patient, would you mind to give me feedback afterwards? That's so much easier, because then I pay a bit of extra attention to what the person is doing. And then I just flag stuff that we can discuss afterwards. Same thing for what, you know, eventually goes down on the sheet. So if you want those assessments to be useful, both for you as a learner and also for the learners, and if someone asked me to fill up a form 5 days later, unless this was like something very extraordinary, I will say no. Like, what am I going to see 5 days later? Like, it's going to be completely non-specific, and it's going to be totally useless. And yes, I can tick the boxes, but that's not the purpose of this. So it's okay sometimes to decline if you feel that, or people ask you to fill up an evaluation about stuff that you haven't even observed and they did completely independently, like a procedure, you weren't there. And the only thing you can comment about is the result, but you know nothing about the process, which is really what we're trying to comment about. So I think some of them are okay to decline. If they're asked ahead of time, then please do make an effort if you can. And if you want to ask some of this evaluation, either EPAs or any feedback, much easier to ask ahead of time. So if you go to a family meeting with a staff and you want the staff to comment about how things have been going, please tell them ahead of time. That's really help your job as a teacher.
Thanks. So moving on to some tips for teaching on rounds, looking at every individual patient, even if it's not the most active patient, there's like 1.5 million things that you can teach on in the room. So here are just like a couple of examples. So the goal is to find something, even if it's something very small, for every patient that you're rounding on. And I'm not saying to slow down rounds by spending 5 minutes per patient doing a big teaching thing, but you can teach, even things that you don't think are teaching can actually be teaching. So thinking out loud is an example of teaching. So for example, the nurse at the end of rounds, just as you're about to walk away, says, "What do you want me to do with the Lasix?" Turning to your resident and saying, given that the patient is nearing extubation and has been volume positive for the past several days, I think it would actually be helpful for their weaning and trajectory to give them an extra dose. So yes, let's enter that extra dose, and we're going to assess their volume status on night rounds. And if they're not negative, we're going to give them more. So that's an opportunity for teaching. And it took an extra 15 seconds, whereas just saying, yeah, give 40 of Lasix doesn't give them the opportunity to understand the rationale behind the decisions that you're making. Other things that also don't slow down rounds would be X-ray interpretation. Get someone to interpret the X-ray. Do you like the way the line is positioned there? Where do we look for the endotracheal tube? Things like that. There's a plethora of medical devices and monitors that you can do quick 30-second teaching on, looking at the arterial line waveform. Is this overdamped or underdamped? How do we determine the difference between that? Look at the ICP waveform. What are some things that might change in a patient who has less compliance because they've just bled into their brain, things like that. And then my personal favorite is to do some what if scenarios. And I like these because not only do they make maybe an otherwise stable and somewhat not super exciting patient an exciting learning opportunity, but it also equips residents to deal with stuff that happens in the middle of the night. So, you're rounding on a patient who's, been doing their trach weans for the past week and whatever, do a what if scenario. So, Julie or David or Bob or whoever you're working with, what would you do if you get called at 3 a.m. by the nurse saying that the patient's actively hemorrhaging from their trach? Okay, let's talk about that in more detail. And you can spend 30 seconds doing these little what if scenarios. What if, the patient self-extubates at 3 a.m.? What would be your first priorities in managing that situation, etc.? So I've got a couple of examples about teaching on rounds. And this is me just banging through a list of however many patients and some of the topics that really did not slow down rounds that we talked about during a typical morning. So 55-year-old guy admitted to the ICU for ARDS. We listed the Berlin criteria and we talked about some of the different ventilator targets in ARDS, plateau pressures, driving pressures, volumes per kilo. Great, that took 15 seconds. 24-year-old guy admitted with a polysubstance overdose who's now waking up. What a great opportunity to talk about some of the medications that are commonly used for delirium. A 60-year-old woman who's here for a necrotizing pneumonia who's now doing trach weans. We talked about common trach pathways. Why do we put trachs in? What happens when she's eventually liberated from the ventilator? When do we do cuff down trials? What's the next steps? We downsize, we do corking, we decannulate eventually. 70-year-old guy admitted with septic shock. He's now got AFib with rapid ventricular response. So we talked about pharmacological managements of that. A 20-year-old lady with a traumatic brain injury from a car accident. Take them into the room to the bedside, show them how you evaluate GCS and do your quick neurologic exam for a brain injured patient in the ICU. And then you get the opportunity also to examine the patient with other people around too, which is kind of nice. 80-year-old lady post-op from an perforated ulcer who's kind of getting close to being extubated. We talked about readiness for extubation. We walked into the room and I showed them physically how to check for a cuff leak. A 60-year-old lady with a subarach. We did, what if you're called for a decreased GCS in the middle of the night? What are the early and late complications after a subarachnoid hemorrhage? So these are little things that really don't slow rounds down, that are a really good opportunity for teaching. Was there something in the chat?
No, I
okay.
was just curious to ask people what else, because again, a lot of you guys have been, and ladies, sorry, I've been teaching already a fair bit. I think that's actually a very big challenge, and don't think that staff do this very naturally. I think this is one of the biggest struggle when you're around on faculty, to try to balance patient care, teaching, families. So I'm curious to see what people, So sometimes when you review patients in the morning, you have, oh, this would be necessarily a topic. So again, sometimes you need to offload your brain a little bit. I do a lot of pre-rounding on my patient, not so much because I don't trust anybody, but just because I don't know, maybe I have trust issue. No, I'm joking. It's really because the cognitive load on rounds is pretty high. And if you've already reviewed things ahead of time, that actually free you some cognition during rounds. So I think my needle has moved a little bit over the years, maybe because at Sunnybrook, the rounds are never ending, because we as a staff, at least, we see a lot of patients on rounds. So it's just, so I think it's debatable how much I'm always been obviously a big fan of teaching on rounds. I think sometimes circumstances make it extremely challenging. And don't forget that if you teach for an hour in total during round, you've delayed sometimes decision making about the last few patients you're going to see for a while, and disrupt a bit the schedule, and the nurses are not at the bedside, and so it's not without impact on just patient care sometimes. So I think keeping it short is good. I think keep it at patient focus. So I tend not to diverge too much into more general teaching points, and just keep it really focused on the decision for that specific patient and the rationale to do that, and how those decisions are made. And sometimes if there's no time, so and some of you may have seen that, but sometimes I'll just flag something and I'll say either we'll come back to it this afternoon, because often between 2 and 4 there's a bit of time. So sometimes before evening and over, I will just go through a series of things that we've raised on rounds. Or what I've been doing also is just giving people mini homework and say, okay, if they don't know, we say, okay, you go and look it up after lunch, and when we come back, we'll discuss all the little topics. So I gave people missions so that it shortened a little bit the interactions on rounds, and encourage them to go and look it up for themselves. And then we can discuss as a group after what they found, and then everybody learned from each other. So choosing patient ahead of time obviously is probably a good thing to make sure that it's going to happen. Yeah, that's good too. So you're doing something and you haven't explained, so you can say, why am I doing this? And that's often, sometimes a fellow will suggest something, or will, do something, and I would do the same. I would ask the rest of the team, do people understand why that's the decision that is being made? And that, again, that is part of what I call keeping it close to patient care, and just making sure that people understand the rationale for the decisions that are being made. Try to do in-room teaching. You mean not the call room, you mean the room of the patient, correct? Yes. Okay. Perfect. Just clarifying. Yeah. And my last comments about that, my last comment about that is, I think you're very right, Alyssa. A lot of the visual things often trigger us to kind of go on and teach. Try to think about, try to get discuss. Don't forget, it's not all about medical expertise, right? So there's aspect of communication, there's aspect of interprofessional care. So if you end up in a situation where you don't feel very comfortable or not very proud of how you manage situation, which happened to me all the time, it's really nice sometimes to take 5 minutes and reflect about the team of, you know what, I'm not super happy about how I managed this interaction with the consultant because I lost my patience a little bit, and that was not very constructive. And what can we do to prevent those kind of knee-jerk response and have a more constructive conversation? And then it's not about expertise or anything, but it's about a lot of the behavior that are important, how you work, and those things are not always explicitly discussed, but they are learned. People will watch how you behave and integrate that in the way of doing. So especially if you're not very happy about how you manage a certain situation, not necessarily clinically, but more in terms of interaction with interprofessional staff or their consultant, sometimes super helpful. And I've had great conversation about that. And that doesn't take either a lot of time, and it can be done later on. So lots of things to discuss. I think sometimes around the time management is the biggest issue.
Absolutely agree with that. So why don't we move on to some procedural skills teaching? Oh, sorry, was someone else speaking?
No, I think there was just
Okay.
more reflection about the in-room teaching.
Got it. Okay, so yeah, I think this was the diagram that David was mentioning earlier about mastery learning, and what our job is here, especially for procedural skills teaching, is we're trying to move people from conscious incompetence, they don't know how to put that line in, they don't know how to put that chest tube in, all the way over to conscious competence during their rotation, or eventually unconscious competence, which is the goal of the expert. Sometimes what we do though is we have to take people from this quadrant of unconscious incompetence into the conscious competence zone. So this is people who think they know how to do something, but they actually don't. So in a perfect world, procedural skill teaching happens in a sim lab, and there's an instructor who's breaking it down slowly, and then the learner will speak, talk the instructor through it, and then ultimately have their own hands-on experience. But in reality, this is when our procedural skills teaching and learning happens. It's in a patient in a dark room at 4 a.m. when they their leave of fed requirements are going up and they need their central line put in. So what are some of the strategies that we can use in order to make sure that we're teaching and balancing patients safely? And I think that patient selection is really key to this. There's a difference between the agitated bleeding patient with severe coagulopathy who has no IV access, who needs a massive transfusion, versus the patient who's intubated, sedated, already on peripheral leave of fed, where you have a little bit more time. And I'm not saying that learners can't get involved with line 1. You can still get the resident to participate without compromising safety. Get the tray ready. We're going to do this line together. Get the lines flushed. Show, maybe you're the one that's holding the needle, but ask them to point out on the screen which one's the artery, which one's the vein, and what do you want me to do to distinguish between them, etc. So keeping them engaged in the process, they can stitch in the line at the end, or maybe after you've done the dilation step, get them to help you feed the line in. These are things that it would take us 30 seconds to do, but for the learner, that's some hands-on experience that they otherwise wouldn't get. The other thing that I do is I ask them if they've seen a procedure or watched videos as a first start, because don't assume that people have seen or learned a procedure before. I ask them to talk me through the steps of the procedure. You can get to know what the learner knows and doesn't know very quickly when they're describing the steps of the procedure. And then I would recommend constant supervision with real-time coaching and corrective feedback in the moment as a patient safety issue. So if you see that they're doing something wrong, just say, pause, why don't we just slow down for a second? I'd like to be able to actually see the wire in the vessel before we dilate. And it can be a bit tricky because, sometimes you get a PGY 3 or 4 anesthesia resident who's been doing lines for, their whole life and are still, making some mistakes that need to be coached out of them. So I oftentimes frame this as tips, and I'll say, I'm going to talk you through it the way that I like to do it. I know that you've done many lines before, but I want you to have, some additional, tips that I've picked up over the years. And then that way you can still kind of get them to do it the way that you want them to do it, without them feeling like you're speaking down to them or teaching them something that they already kind of know. And then, it's helpful to establish a number of pokes in advance of the scenario so that people don't feel like you're taking over because they're doing a bad job. You can just frame it as, for me, if there's going to be more than 3 pokes, at the baseline, I'm sure you're going to get it in no problem. But for me, that's my personal rule. And so if we've poked 3 times, I'm going to take over for that step, and then I'll tag you back in. There's some activity in the chat here. Dominique, did you want to read through it?
Relevant, no, just a comment to say that if you're not going to let resident do something, just explain why. Because those even if it's just, I haven't done enough of this procedure and I really need to practice, and you're a critical care trainee, so yeah, you have the priority and that's just the way it is. But it's nice to explain why, or if the patient is sick or there's a specific risk, just explain. And often their response is I found it quite informative about sometimes their approach to care. Like if they look upset because they've been bypassed for a procedure that was high risk, that sometimes tell me a little bit about that worries me a little bit about the resident, because everybody should understand that if there's a concern. Yes, and then Nassim was just making the fact that absolutely we learn things from each other's all the time, and that has not much to do with level of experience or expertise. So it's always, that's the beauty of working all together. So Nassim also brought up a specific challenge. Is that one of the cases that you had, Alyssa, like someone who's just not take no as a...
I don't think so. I don't think I've ever had that happen where someone like literally did not let me take over if I asked to. Like, yeah, that's brutal.
I think it's absolutely fine to have. I think you should have roles. Don't forget that all the stuff we do in clinical environments, it's always a balance between supervision, i.e. patient safety, and teaching. So there's no reason to compromise patient safety under any circumstances, just to promote teaching. I think both can be done simultaneously, but patient safety come first, and there's no discussion about that. So I had that one happen to me where I literally said, now you put the probe down, you remove your glove, and you move away from the bedside now. Because there was just ongoing poking in a very unsafe manner. And I was a resident at that time, a senior resident, but still maybe just a year or 2 above. And that was, again, that's often, I think those big safety issues are probably worthwhile to flag to the rotation supervisor, honestly. They may happen in isolation and maybe nothing, but these are the things that I would red flag for sure, because they're pretty rare. So Ryan, can you speak of your strategy? Because there's a lot of text there, and I guess I'm sure you would express that better than me.
I think that people are sometimes very stressed during procedures, and if you take over, they think that it's because they're incompetent or they've done something crazy wrong, and they don't realize that in the back of your mind, you're thinking, I have a crashing patient 3 rooms down. I need to get out of here quickly. But also, I think that I try to set the expectations before. So I try to tell them Here's what's going on, big picture, and I'm going to try and do this part quickly. That way it gives you more time to do this part. And I try to tell them, if this isn't going well, here's what we're going to do instead, so that they don't have to do all of that thinking when they're already stressed in the middle of the procedure. They already know what to do if it's not working, what their backup plan is. Yeah.
And I think it's good also to acknowledge that sometimes we take over just because are stressed ourselves about a specific airway, for example, right? So the more comfortable people are with a specific procedure in a certain context, the more likely they are to let somebody else give it a go because they'll feel comfortable rescuing if there's a problem. So sometimes I'll just say, I'm sorry, I'm not feeling very comfortable with this, and I want to give myself a bit of extra time so that I don't have to rescue at the last minute. So I'm going to stop you after if so and so happen. So that it has not much to do with their performance, it really has to do with me. So those are all tricks to get around those issues.
Absolutely. Great discussion. So just kind of going through didactic teaching. So when you guys are going to be asked to give a lecture or give a rounds at pretty much every site at some point. I would just encourage you to, pick topics if you have the luxury of picking topics that are relevant for your audience for sure, and stuff that you're comfortable and happy teaching about. So you're going to have to pick a format. Whiteboard talks are usually the ones that, in my opinion, are best received compared to PowerPoints from a learner standpoint. There's also a lot of good case discussions and discussions around patient cases that can happen. So that's also a good one that's kind of less prep work and well received. Create, at least in your mind or objectively for the learners, a list of outcomes that you want to achieve for the session. Review the relevant sources, and it's really helpful to present your material alongside relevant and reality anchored cases for the learners to work through that's also relevant for their rotation. So picking an ECMO case to teach around at Sunnybrook, probably not the best for your PGY2 ortho resident, but try to make it relevant for the place that you're at and the people that you're working with, and make sure that they participate, and try to summarize your key points at the end. So we had talked about teaching scripts, and these are kind of things that we as teachers or people in a teacher role are very comfortable talking about. And through the years, you're going to develop your own, and you probably already have your own teaching scripts, to be honest, like things that you love to talk about on rounds, or topics that are near and dear to your heart. For me, I love talking to internal medicine residents, and I guess other residents, about trachs, because they all have patients who are trached on the ward after their long complex ICU stay, and they're terrified of them. So this is something that I absolutely love teaching about, and I teach about with pretty much every learner that comes through the ICU that it's relevant for. We talk about, why to put them in, cuffed and uncuffed trachs, the usual pathways, and some of the trach emergencies that they might be asked to develop. So your homework, if you haven't already done this, is to pick 5 common topics that you like and make a maximum 5-minute talk about them. And this can be the basis of your own teaching scripts ultimately, and can eventually be developed into kind of bigger lectures. Dominique, did you want to chime in? Oh, no, sorry. It looked like your box got highlighted, so I thought that it meant that you wanted to say something.
No, so at the end maybe, but not right now.
Okay, sounds good. So some of my favorite topics to teach around are kind of like emergencies that residents might need to start management for before help arrives. So things like big bleeding events, seizures, trach bleed, trach fell out, super duper agitated patients, vent alarms, things that we have a lot of expertise in that they don't really know a whole lot about yet, is very, very well received. Thanks, Dominique, for that comment in the chat. It's been interactive. I wanted to get through so we could give everybody a break. Okay, so that brings us to our next part. But why doesn't everybody take I don't know, should we do 5-minute break, 10-minute break?
Yeah, what people want to do. Do you want a break? You want to just keep going and finish?
No,
earlier?
we have to have a break. 5-minute break. We're going to do a 5-minute break. So everybody comes back at 3:25. Okay. Sound good to everybody?
I like that. Directive teaching.
yeah, I'm making the decision, because otherwise people waffle and then everyone's like, no, we always wanted the break. Why is everyone telling us to push through? Okay.
Great.
Anyways, see you guys in 5. Thanks. So I think Simon is going to be putting us into our small group rooms now, so that we can talk about some cases. But one last plug is, I know that this is teaching, a session about teaching, but as a plug, if any of you guys are at all even remotely interested in helping me out with some of the sim sessions that we do for the internal medicine residents, please email me. It's always amazing to have ICU fellows as facilitators, always looking to recruit people for that. There's a couple of sessions throughout the year, so get in touch. Okay, into the rooms now. Thanks, guys.
Hey, Simon, can I be put into a room, please?
Simon, everyone can go now. What's the plan?
Hey Cam, I think Dominique wants everyone back in the main room first. I think she has a message.
Okay, sounds good.
Thanks, Cam, for being one of the facilitators today from your cottage.
No worries. That's great.
Are you inside or out? Is that outside?
This is outside. I just blurred the background so people wouldn't judge me. But now that you've told everyone, it's okay.
I kind of want you to unblur it so that we can see like some scenery.
I don't even know if I know how to do that. I can try to.
So I think Dominique is going to join the group and then give a couple of last thoughts.
Sorry, team, we've been sent back to the main room. I could see the countdown, but you may not be able to see that. I'm assuming that everybody is back, right, Simon? Some people are probably had to leave. Any take-home message from your discussion in different groups, Alyssa? And I think, Cam, you were kind enough to facilitate one from wherever green and lovely you seem to be.
My group actually had outstanding discussions, like way better than the previous group of critical care graduates ever did.
Is that your positive feedback to the group?
Yes.
Not specific, but still very, very positive. Yeah, as David put it, you should blur your background because this is a bit upsetting.
Yeah, I think the one thing that came through was there's many years of experience, at least in the group that I was speaking with. And, you know, people have encountered many of these scenarios before and they have lots of good strategies.
And I think that kind of bring the points also that, I mean, we don't always discuss these things between ourselves, but this is a big part of what we do. So I would just encourage you also to talk to each other about those things. Like if you have a challenging trainee or challenging interactions, teaching interaction, discuss with others, ask them what they would have done. Because, you know, it's nice to develop some tricks that you can use in specific situation. And, you know, those things, it's practice. Like it's like anything else. The more you do it, the more you practice. So I just wanted to highlight 2 or 3 things. I think we've said that many times during, Alyssa mentioned it many times and during the conversation. I think as a teacher, as an educator, I think setting the tone right so that learners feel comfortable asking questions, showing their ignorance, and helping you to understand what they need from you in terms of education is super important. And developing some relationship with people is really key so that they accept whichever comment you have to make about their performance. And that it's limited in our teaching environment because often you're going to work with someone for a few hours, a few days, a few weeks at most, but it doesn't take much to do a bit of chit chat and understand a little bit who this person is before launching into some kind of debriefing. We talked about patient. I think being kind, approachable, patient. It's hard at 3 o'clock in the morning or when you haven't slept much for the last week. But if you don't feel you're able to do that, then I would just say take a pause or explain that, you're a bit tired tonight. It might not be the best in terms of feedback and interactions, but you'll do your best to certainly support them with patient care. And then be kind to yourself. I think sometimes the circumstances are not right. And you're going to feel like, oh, I'm not doing a good job, or, oh, I did no teaching today. Well, sometimes, guess what? It's not working and it's not possible, and that's okay. There's a lot of things just by the way you're behaving at work and the type of interaction that you're doing. There's a lot of role modeling there that, trainees will pick on, even if you don't do formal teaching. So, again, our environment are challenging, so give yourself a break. We do our best, but sometimes it's not always possible, and that's okay. And the resident will understand that. They can see how busy things are sometimes. So don't be too harsh on yourself. Any concluding remark, Alyssa? I'll leave you the last word. Thank you so much, by the way. But go for
My
it.
pleasure. Thanks everybody for coming. I think one of the only like last closing points is, you know, when you're interacting with learners in a clinical environment, one of the most important things that'll help them shine is to set expectations, you know, and to tell them what you need from them during that shift. And that's kind of key to many of the cases that involved kind of performance or some patient safety related issues. Is a lot of these things can be mitigated by just being very clear with them upfront about what you need from them during that shift in terms of communication and stuff like that. But anyways, yeah, thanks everybody for coming. Hope you guys had some fun chatting through all of this. I certainly did, and I hope everybody has a great afternoon.
Bye. Go enjoy your outdoors, Cameron.